All right, we're going to go to the skin.
Okay.
And we're going to spend
I'm
quite
ready.
some time necrotizing in the skin. So this is Necrotizing Soft Tissue Infections by Stevens and Bryant, New England Journal of Medicine, December 2017. And this is written by 2 infectious disease specialists. So with that as sort of a predication, there are some things that are interesting in here. It's a little more detailed than what we usually need, but it's also kind of interesting. So we'll talk about this. The NSTIs, which working in the ER, we both work in the county hospital emergency department, and I am amazed how much of this we see.
Yeah.
Something that's supposed to be rare
Is
isn't
not
in
rare.
our place at all. This is basically widespread tissue destruction. This isn't just I have a little infection. It's basically anything from the epidermis all the way down to muscle can get necrotic. It basically just dies and gets necrotic. And what fixes that is steel. Yeah. So this is a surgical diagnosis. This is not an antibiotic diagnosis. This is surgeons get involved. So our job really is to figure it out and get a surgeon involved. This article goes into a whole lot of detail about the causes, the mechanisms, and some of it's kind of interesting, to be honest. It doesn't change a lot of how we approach it, except the pitfalls. I think the pitfalls in this article are very well done. So let's get into what they get into in this paper. They start by identifying some specific entities, which I am not going to bore you with, because honestly, it doesn't really make a difference on what we do, because the clinical approach is similar to all of these specific sort of ID kind of entities they pulled out. But there are a couple ways that they group it that I think are kind of interesting. One is the neck fash concept of what they call it type 1 and type 2. But I do think it's interesting, the idea that one of them, type 1, is polymicrobial, where bacteria are kind of working together. Type 2 is monomicrobial. A single organism is actually causing the problem. Let's start with this sort of polymicrobial issue, because we are familiar with these. These is basically anaerobic and aerobic organisms that kind of work together. And the group of patients is that you know who these people are. They're the elderly and people with underlying illnesses, particularly things like diabetes. So this is that diabetic older person with a little neuropathy of their foot who had a cellulitis, and now it is nasty. You'll see it in people with rectal fissures, colonic, urologic, gynecologic procedures, anything sort of down there where there's a lot of organisms and they're working around sort of your perineum area. Decubes are an area, hemorrhoids, again, all of these things set you up for aerobic and anaerobic organisms. It makes sense that the areas that this happens and the people to whom this happens. What's the scary thing is that plain film with gas in the tissue, because it can look like gas gangrene. It isn't. Okay, it's not gas. In fact, I hear that misnomer frequently in the ER, where particularly medical students will look at an X-ray and say, "Oh, it's gas gangrene." No, it's gas in the tissue caused by these organisms kind of working together, these aerobic and anaerobic organisms. So and again, it's a synergistic kind of a deal. Diabetics, it starts in the feet, and rapid progression is one of your big trouble. Rapid progression up the leg.
And we draw the line.
And then the next hour it's higher, and the next hour it's higher. You know it's terrible. Or if you see a diabetic who has what looks like cellulitis, but they're tachycardic and they're febrile and their blood pressure's a little on the soft side, that is neck fash. That's somebody who basically is way sicker than just cellulitis doesn't do that. Okay, this is a sicker thing. So a diabetic with, they're sick with cellulitis, not so much. That you have to worry about neck fash. And then there's certain places in the body where we know to worry about this sort of mixed anaerobic aerobic thing. Ludwigs Angina, which is the submandibular space in the mouth where you can occlude someone's airway because of that woody, thickened sort of floor of the mouth.
Brawny edema.
Brawny edema, exactly, the description, which is the picture. If you're looking at these slides, that's what the picture is. Lemierre syndrome, which is basically your jugular vein gets thrombophlebitis from Fusobacterium in your mouth. It causes a sore throat, and then you get this neck pain, and you can be septic or not with that one, but you basically get thrombophlebitis of the jugular vein. Fournier's gangrene, we all know about, we all worry about. Now, this is a man disease, okay? This is, by definition, a male genital area, gluteal muscles, abdominal wall, perineum, rapidly spreading, severe pain. And severe pain, it kind of filters to the top of things to really worry about when people have this infection, because it usually hurts quite a bit. And they also mentioned that people have had surgery anywhere down near their sort of colostomy, colon area. They can end up, or have wire sutures in place, which some people do, can get another form of gangrene. Again, this is not gas gangrene. This is actually necrotic tissue gangrene of these two organisms working together. That's the two organisms. That's type 1 neck fash. Again, the diabetic, anaerobic, aerobic. The type 2 is monomicrobial. And the thing about this that's scary is this isn't the person who you think of as a risk. This could be Jan. This could be me. This could be anybody in this room. This could be you listening to this.
This is the one you read about in the paper. Like
this
the
is
healthy person.
Right, the flesh-eating bacteria, the healthy person.
Yes.
This is what took out, I think, Jim Henson and Cameron Diaz's dad. And so this is a monomicrobial, any age group, healthy people, group A strep. So this is
They
pyogenes.
just get the bad one.
They just get the bad strep. It can be MRSA as well, or Ehrlichiosis, or Ehrlichiosis hydrophila, or Vibrio vulnificus, but it's a single organism causing this terrible necrotizing infection. There are a few things they mentioned about gram-negatives I'm going to skip because I don't think that's pertinent. What's really pertinent in this section of this type 2 is the group A strep. It's a strep pyogenes with basically, you get it. You have at least the lowest end is a 1/3 mortality. The highest end is almost half. It's terrible. And the sicker you are, the more likely you are to die. It's an infection of the deep tissue. It's the get-go. And there are two ways it happens. One is there's a portal of entry, how it gets into your skin. And the other is no defined portal of entry. It just spontaneously happens. And that's up to half of these cases of group A strep infections. If the portal of entry group, the half that actually has a reason for this group A strep to get into your system, are things that that make sense. Something that's a break in the skin, an insect bites you, chicken pox, you have a cut, you are an injection drug user, you just had some surgery, you have a surgical incision, you had a baby, and you had an incision with that. So these are all there's a reason for this to have gotten into your system. And what happens is initially the area will be a little bit red, but really fast, over 24 to 48 hours, it gets really inflamed. The skin gets dusky because it's dying. You get bullae, often hemorrhagic, because again, the vessels now are exposed, it bleeds into these bullae, and the skin gets gangrenous and completely sloughs. It can happen in front of your eyes. This can happen during a shift. In 4 to 6 hours, they go from just a little bit of red to, oh my gosh, what is happening here?
Those ones who don't have an obvious break in their skin, like the IVDA or an insect bite, don't you think they must have had some micro break
You
in their
think,
skin?
right?
They must have.
Yeah, because how else does it get in there?
How does it make sense?
It doesn't, right?
You just
It
don't know
doesn't.
that it happened, but it's just got to have happened.
And you think, right? And it has to get there. So this one, these patients, these are the ones with the break in the skin. It's growing right there where it started, and but it basically becomes bacteremic, meaning they can also become sort of metastatic. They can get infections where the bacteremia ends up lodged. They get toxic, they get septic, they go into shock, they get a super high fever, and they die. And they die pretty quickly. It's one of those, usually within 2 to 4 days, they'll die. The no portal of entry group, which is the group that Jan was just saying, is the scary group because you may not find anything. And it theoretically can start at the site of a bruise or a muscle strain. So I'm working in the garden, I bang my elbow, I have a bruise there, and then, in 2 days I get a little bit of a fever, and I'm kind of nauseated, and I have a little loose stool, and I just don't want to eat anything. And what's happening is that group A strep is growing where I had that bruise or I had that muscle strain.
So we should all walk around in bubble wrap.
Apparently. It's just terrifying, actually. One of the things that helps you here is that their pain is more than you would expect from that muscle strain or from that bruise. It's like, why are they, in fact, so much pain that they often will eat opioids to control it.
That's one of those,
that is one of those hallmark, red flag,
what's
whoa,
going on
this
here?
doesn't make sense. Because the cutaneous findings come later. They get sicker first, and then the skin findings. It's not like the case where there's already a portal of entry and the skin gets crazy. This comes later. So because this diagnosis is often delayed, the mortality rate of this one is high. It's 70%. So it's because we often delay it. We think it's a bruise. The patient may think it's a bruise. When you have these group A strep infections, like all of these infections, it's immediate surgical treatment. They have to go in and basically cut it out. And often they'll take them today, and then they'll take them back again tomorrow to the OR, and they'll take them into to the OR the next day. Sometimes they'll take a limb off. Sometimes they'll disarticulate a hip just to get that thing under control, to try to get that strep infection under control. And one of the things that's fascinating
this was interesting,
is non-steroidals, especially with group A strep infection, and they're not sure exactly how, although I can see some mechanisms that this might work. But if you have this, so I bruised my elbow gardening, and it hurts. So I started to take ibuprofen because it was bugging me. So I'm going to take some ibuprofen. It turns out that it can basically worsen the disease course or accelerate the disease course. What it's actually doing isn't entirely clear, and maybe you just don't know it's hurting you more and you wait a little bit longer. I don't know, but non-steroidals increase the risk of this being worse by the time you come in. So that's the type 2 of the necrotizing infections. The third big group, and this is the group that kind of think of classically, is the clostridial infections. This is the true gas gangrene infections. This is clostridial myonecrosis. This is muscle that is necrosing now. This isn't just skin and skin appendages. This is all the way down to muscle. This can also be spontaneous, but it is usually post-trauma. And the trauma is usually deep trauma. So what you've done is it's either a crush injury or you have something that's penetrated deeply, and now it's an area that's kind of devitalized. It's not very well perfused. And remember, Clostridium is an anaerobe. It likes growing in this anaerobic environment. So these deep penetrating injuries with impaired blood supply, it loves to grow there. It also, though, will grow in places where you've had procedures, like certain kinds of surgeries, or particularly OB surgeries or GI surgeries. So it can also kind of grow in those areas. And there's some specific organisms I'm going to mention in a second. So and these are infinitely testable, especially this GYN procedure one. So we think about Clostridium perfringens as the gas gangrene, but there's also Clostridium septicum, which is from a GI source. And the GYN source is Clostridium sordelli, S-O-R-D-E-L-L-I, those of you who are driving. And that one's kind of interesting because they present a little differently, and I'll get into that in a minute. What's fascinating about the Clostridial myonecrosis, all these sort of gas gangrene kinds, is they don't tend to get a fever. So it's growing in there anaerobically. It's just doing this awful release of toxins and gas and all this stuff. So you get systemically ill. You get hypotensive, and you get this massive capillary leak to the point where you can end up with a hematocrit as high as, get this, 80%. Wow. Can you imagine a hematocrit of 80%? You have 20% plasma and all these red cells. It's like, oh my word. And a white count can be as high as 50,000. And in fact, with that Clostridium sordelli that women can get post-gyne, it can be as high as 150,000. Wow. So the white count is in that, that gets my attention kind of white count range. Yeah. Gas gangrene, whatever the type is, mortality rate is 70% if you're having a good day, and 100% on the higher end. And this is 2 to 4 days after getting admitted. It just kills you. It's just a terrible, terrible thing. There are two tables that are in the that have been kind of sort of remodeled here onto the slides that you can actually look at, but they look at the risk factors and the organism. And this is an area that if I were writing tests, I would love to pick and choose from these tables of what's the risk factor and then what's the organism. And rather than sort of bore you with kind of walking through these, you can either read them or we've talked them through a little bit, but these are summarizing for you to go back to, because I suspect that there will be some questions that come straight off that slide. Now, the one thing I like about this article is they do talk about where are the pitfalls? Where is it that we miss this? Why is it there's certain patients that slip through the cracks? And things that can help you differentiate just a regular cellulitis from a true necrotizing soft tissue infection are, if there's just been a surgery recently, and now we think cellulitis a lot, but just raise the hackles on the back of your neck a second. That might be actually worse than that. Definitely pain out of proportion. There's nothing good that causes pain out of proportion. Nothing. It's ischemic or dying, or both. So I don't care what it is, pain out of proportion. So that should worry you. Hypotension, of course. Hemorrhagic bullae are never good. Okay, and if there's somebody who's systemically ill, you've got to worry about an NSTI. And skin necrosis, of course, is a concern. The people with group A strep infection, but almost all of these will have this rapidly crescendo pain. So they'll be fine, and then within a matter of short amount of time, an hour or two, they're not. And the pain usually precedes all the end organ dysfunction and the hypotension. So that's your warning sign. That's your little window of opportunity to maybe make a difference in somebody's outcome on this. Because once they're hypotensive and their organ dysfunction, pretty much the cat's out of the bag. And if they've had non-steroidals on board, then...
Or they have diabetic neuropathy.
Right, and they can't feel it, so now they don't feel the pain as much, and now, again, we're further down the line. Yeah. And again, don't attribute it necessarily to post-traumatic pain or post-surgical pain if it's out of proportion. Right. Like that thing should just really warn you. Yeah. So severe pain, no clear cause, and I'll tell you, if somebody comes in, we had a case of this about a year ago where somebody came in and had just localized, really terrible pain on their chest wall. Nothing, tender to really tender, really painful, no trauma, no nothing, and within about 6 hours had complete necrotizing skin infection of the skin with no reason at all to have it. Yeah. So that was our only clue, was like, what is this? This is so weird. Why is this happening? That was our only clue. Yeah. Imaging you can do, but please don't wait for an image to get the people on board who have the scalpels. So a lot of modalities may show things like soft tissue swelling. They may show air. In fact, air is something that's worth a plain film and taking a look, or even a CT and taking a look for the air. That should make you really worry. But if there's no air, it doesn't mean it's not there. It doesn't mean you're not having a necrotizing infection. So imaging is fine if there's air. If there's not, you still have to worry. And if there's gas, you call a surgeon right now. Now, what they're going to do, and actually the diagnosis, we suspect it. There's no imaging that actually diagnoses it. What truly diagnoses it is the operating room. Right. So they go in and they find the dead tissue. They do biopsies and histologies and Gram stains. They will make the diagnosis in the OR. That's where they actually clinch the diagnosis. And they decide up there how far they cut, and all of this stuff will guide their management up there. Now, part of our problem, though, is we're sitting in the ER with somebody who banged their elbow or somebody who had a little bit of surgery. And is this a wound infection or is this an NSTI? There are surrogate markers for this. Now, remember, this surrogate means it's not the real thing. It's something that might be happening because of the real thing. So there's several things that might help you. So I love this one. A CRP greater than 200.
Yeah.
Which I think would
Yeah.
get my attention, a CRP of 200.
Yeah.
I would ask the lab to make sure that's correct, that's so
Right,
high.
right.
A white count elevated with a left shift. That I'm
So
not sure how much that
nonspecific.
helps me. An
Yeah.
elevated creatinine, I'm still
Yeah.
not sure how much that helps me. So that I'm not sure helps me. If, however, the white count is 150,000, again, this is a positive thing. I think I'm worried, not that I'm not worried about it, but boy, now I'm much more worried. And that's that sortoli, that Clostridium sortoli. If the white count's 150,000 in a gyne person, that's what's causing the trouble. If you have a white count around over 15.4 and a sodium less than 135, there are some papers that say that if they don't have either of those, that has a decent negative predictive value. But I'll tell you, I'm not impressed. And the Laurents score, which is something that actually was studied quite a bit, put together more than just those two factors. It put together your sodium, your creatinine, your glucose, your total white count, your hemoglobin, and your CRP. And it did this laboratory risk indicator for necrotizing fasciitis score, ranges from 0 to 13. And what this is supposed to do is give us a positive and negative predictive value to help us know who's safe to go home and who's a slam dunk come in. And actually, it's more the who's safe to go home. And I have to tell you, I don't use it. I don't know anybody else who really uses it. The surgeons love it, but they only love it because they can say, oh, look, the Laurents score is too low for this to be an STI.
Right.
But the negative predictive value in the best of circumstances is 96%, which is really fine if what you might miss in that 4% won't kill you.
Right.
But it will kill you. And the negative predictive value on some studies is as low as 86%, meaning it's missing 14%. Not good enough for me. So all these surrogate markers.
It's a good thing to be aware of, though, since your surgeons like
It
it. They'll
is.
ask you what's the Laurents score, and you can say it, and then you can remind them.
Right, and there are calculators you can have on your phone to calculate. You don't have to
Yeah.
memorize anything.
Yeah.
You can use the calculator, but
know that it's not perfect.
It
You
isn't.
gotta know
Stick
that
to your
because
guns
you have
if
to
you
fight
really,
for your patient.
You do,
Yeah.
you do, absolutely.
Yeah.
And then what they did in the paper as well is they kind of put together some pitfalls. So again, if somebody comes in who might have an STI and they don't have a fever, don't hang your hat on them having to have a fever. Remember, it might have been non-steroidals, it may be one of those, in fact, the Clostridiums that don't tend to cause the fever, so no fever doesn't mean it's not an STI. No skin findings. This is a big one, actually.
Yeah.
Well, the skin looks fine because it may be deeper than that. It's what you can't see. Again, this is that pain out of proportion. It's skip lesions running around under what I can see. So no cutaneous findings doesn't mean it isn't an STI. Be careful if you think it's a musculoskeletal injury or it's a procedure, just think again. And one of the things that's probably a useful practice is before you write the diagnosis of muscle strain or bruise or whatever, is just take one step back, take a breath. Could this be an NSTI? If you're still convinced that it isn't, that's fine. But just think about it. It may be a red flag. Remember, imaging, if there's gas, fine. But it may not have gas on plain films, even if it's there. And imaging is not the be-all and end-all by any stretch. And systemic symptoms. So say somebody comes in with a bruise on their elbow, and they're feeling a little nauseated, and they have a little grade fever, and they have a little loose stool, and they don't want to eat anything. Don't call that a GI problem until you're sure that that bruise on the elbow isn't causing the systemic symptoms because they have a developing NSTI.
That's a good one.
Surgery is the mainstay, okay? So the bottom line is you've got to get a surgeon involved. And I have to tell you, if you have a suspicion of this, and yes, the Laurents score isn't perfect, call them. Document when you call them and have them see the patient. Don't let them make the diagnosis over the phone. They need to see these people. This is one of the things you really have to sort of put your foot down about this. They use surgery again to diagnose this thing, and they may do lots of surgeries. And the sooner it's done, the better the patient will do. So it's really important to get this done early.
And if they're not impressed and you still think it might be, then keep that
Keep
patient
them around.
and observe them and watch them.
Because it'll be clear.
Things will evolve.
And it'll be clear within 12 to 24 hours. Now, antibiotics are part of this. Okay, there are organisms that are growing in there. You'd like to decrease their growing the best you can. And what antibiotic you choose depends on kind of what organisms you think might be there, your antibiograms. But the bottom line, it needs to be a relatively broad spectrum. So honestly, you can just grab Vanco or linezolid and then add either piperacillin tazobactam, a carbapenem, or ceftriaxone plus metronidazole. And if you just grab a combination of those two of those mix and match kind of agents, you will have covered pretty much what you need for most of these.
Yeah.
If you are sure, however, it's some other specific thing, you're sure it's group A strep. No. This is the person who bumped their elbow or has a mosquito bite and now they're super sick. You can try Clinda plus Pen. If you are sure it's Ehrlichiosis, this is a freshwater acquired infection. This is doxycycline plus either Cipro or ceftriaxone. If you are sure it's Vibrio, which is a saltwater Vibrio vinificus, saltwater acquired, that's doxy plus ceftriaxone or cefotaxime. Again, this is when you are more certain. It's fine to do the first set of antibiotics, though. This is the
ID specialist.
This is the
who gets
ID
the culture
people.
back and then
Exactly.
kind of narrows down their antibiotic.
Yeah, and so they get into all these specifics.
Yes.
I won't bore you with the rest of them, but just know if you are sure, fine. If you're not, just stick with the broad stuff. We know we resuscitate these people. One of the things to know, though, is that they may not look like they need it, but they need liters of fluid. I think of this as somebody who's like in hyperosmolar state, where they're down tons. What they're doing here is leaking like crazy. They have tons of capillary leak. So 10 to 12 liters maybe every day. In fact, if you ever have one of these people survive and you go up and see them in the surgical ICU, you will not believe what you see. It is somebody who looks like the Michelin Man. Yeah. They are swollen from head to toe because they've third spaced everywhere. It is remarkable. And sometimes they'll actually use albumin to try to keep it in the vascular system, to just try to keep it there for a while. They may get anemic. Remember, they may be hemoconcentrated, but they may actually hemolyze and get anemic, so transfuse if you need to. Every once in a while, they'll get a cardiomyopathy. You're not going to know that unless you do an ultrasound. You're not going to know they have that. But this is a person that just, you cannot get their blood pressure up. They just won't. It makes them really hard to manage. And hyperbaric oxygen is one of the things that's sort of hyperbaric oxygen practitioners love this, because once somebody has survived this, then they can get their hyperbaric treatment to the area. It is not the front end. This is the back end, if at all, for these patients. And immunoglobulin doesn't work for this at all. So they have a diagnostic algorithm in the paper that actually really, it's only like the first 2 steps that involve us, and then everything else in that algorithm in the paper is for either surgeons or ID people, not us. So for us, swelling, erythema, or pain, especially pain out of proportion, gotta worry. If there are no systemic signs, the pain is appropriate for what you see, it's probably cellulitis, erysipelas, or an abscess, and you're done. But if there's something wrong, pain out of proportion, their heart rate is high, their blood pressure is low, their CK is up, which is interesting. I don't usually order CKs. If you happen to have it and the CK is up, or their CRP is up, or the Laurenica is high, that score you're going to do is high, they recommend immediate surgical consultation. I think it's worth, if you're really that worried about it, it's worth just getting people involved right away. Don't wait for the imaging. However, if you weren't really sure and you get imaging and there's gas in the tissue, you're going to call them immediately. Okay, you're going to call the surgeon immediately if there's gas in the tissue. The paper goes into what organisms are what to do. Again, this is beyond what we're going to do. This is way down the line. So if you want to summarize this actually pretty decent article on necrotizing soft tissue infections, it's based on types, based on the organisms, they'll divide it into types. But predisposing factors will help you determine what type of infection. Know that it kills people really fast. Know those pitfalls. We talked about them. Know the pitfalls in making the diagnosis, that pain out of proportion, don't expect a fever, if it's MSK, think about it again, and that surgeons are the people that take care of this. This is a surgical problem. Done.
Yay.